Can you guys hear me okay? Rockin'. Cool. So I'm going to talk about domain adaptation for medical applications of ultrasound. I'm coming here from Butterfly Network, and I'm going to tell you all about a product. So the first thing I'm going to do is I'm going to give you a little bit of an intro to ultrasound, and then I'm going to tell you about the Butterfly IQ. Ultrasound imaging. So this is an example of what an ultrasound system looks like. Ultrasound as a modality has a lot of advantages over other medical imaging modalities. The first is it provides real-time imaging. So with an ultrasound system, you can take a probe, put it on someone's body, and get a real-time window into what's going on. It's considered safe. You can ultrasound someone all day long, unlike X-ray or CT. It's an excellent diagnostic utility, so it's used by a large variety of different medical professionals. And here are some examples. So cardiac health, if you're in a car accident or you've suffered some sort of trauma, you might end up in the emergency room, and one of the first things they might do is take an ultrasound device, put it on your heart to measure your cardiac health. They might do pneumonia screening, so pneumonia can be detected through ultrasound. In fact, today it can be detected through ultrasound more accurately than through X-ray. Abdominal aortic aneurysm. This is something that is routinely done, screening for aneurysms for people with congenital heart disease. Bladder and kidney assessment, ensuring that there's correct flow through your body. Blood flow and plaque buildup in your carotid artery. And of course, obstetrics and gynecology, which is what most people think of when they think of ultrasound. But I want to impress on you is just that ultrasound is really used all over the body: cardiac, lungs, abdomen, liver. It's a very, very popular imaging modality. But it does have a number of important limitations. So the first is that a very, very expensive system can cost up to $250,000. So that means a hospital, even a well-off hospital, might only have a few systems in-house. It might have 3 or 4 ultrasound systems. Somebody calls for an echo to be done, and it could be 20 minutes waiting for somebody to find where one of these systems is and bring it down to the patient. It's unwieldy, so you can see this big, large cart. This is actually, there's a lot bigger ultrasound systems than this one. And one of the real limitations is that ultrasounds require different probes for imaging different parts of the body. The reason is that all ultrasound devices use piezoelectrics, so it's a crystal that you pass a current through. It vibrates at a particular frequency, and you need different frequencies to image different parts of the body. Ultrasound devices or systems themselves are very complicated. So this is just an image from one of many types of popular ultrasound systems. For reference, this is the Apollo 11 command module. So this is what I always think about whenever I see one of these big systems. It requires years of training to acquire images. So this is really one of the difficulties of ultrasound, is it's very operator dependent. So if you call to get an exam, you plop an ultrasound on some part of your body, and the exact angle that you hold the probe will radically change the image. So it requires a lot of time, not only to understand exactly how to hold the probe, but also how to interpret it. It's very, very difficult to interpret ultrasound images because of what the modality is. It's a slice through the body. So when you look at an ultrasound image, it's often not intuitive at all. So these aren't just academic issues. 2/3 of the world's population doesn't have access to any kind of medical imaging. As you can imagine, in many rural areas, it's not very realistic to bring a big CT or an MRI system. So ultrasound has, for a long time, held the promise of being able to deliver medical imaging to a huge part of the world. But again, it's very, very expensive, and a lot of these systems are very large and unwieldy. This one WHO report suggested that 50 million people die every year from preventable causes. So these are certain things like, let's say a woman is given birth and the baby is positioned in the wrong way. So these are things that are very treatable. We can only image the patient and understand what is going on inside. So Butterfly has developed a new device, the Butterfly IQ. It's a single probe that can image the whole body. So I mentioned before that every other ultrasound system requires a different probe to image different parts of the body, which means in a regular ultrasound system, there's 3 or 4 different probes. This is the only device that does full body imaging. It's much, much less expensive. So we're going to sell it for less than $2,000. It images on your iPhone, and it comes with a bunch of automated measurement applications, in particular deep learning applications. So before we talk about the kind of things we work on, I just want to give you a very quick deep dive into, or I should say a very quick shallow dive, into some of the machine learning applications in ultrasound. So really everything that we do is in image and video interpretation. So the most basic thing that we might do is image classification, right? So here there's a number of what I'll refer to as canonical views. So the top left is a cardiac image. This is someone's carotid artery, and this is someone's gallbladder. These are images that if you show them to a medical professional who's been trained in ultrasound, they would immediately be able to classify what part of the body we're looking at. These are some images of what I'll refer to as non-canonical views. That is to say, these are the sort of things that don't show up in a textbook. This is what real life looks like. It's a lot more murky. And very often, with certain applications that we work on, we still need to understand or assess what part of the body the probe is currently located at. There's a number of key point estimation tasks. So this is just one. This is just two here. Oftentimes we want to do things like fetal measurement. We want to understand how a child is developing. So what we might do is measure the spine, and what we'll have to do is train a model to identify two key points. These are particular anatomical locations, and once we can estimate those, we can estimate the infant's development. And cardiac health is a similar key point estimation problem. So here what we're doing, we want to estimate the diameter of the left ventricle. And again, we need to be able to identify in using a machine learning algorithm two very particular anatomical locations of the heart. And if we can do that, then we can automatically assess someone's cardiac health. There's a whole host of segmentation problems. So also in cardiac health, this is a different view of the heart. Here what we're doing is we're segmenting the left ventricle. In abdominal health and kidney health, there's a whole bunch of examples like this where we're trying to segment some part of the body in order to do volume assessment. Sometimes we want to find a number of different organs in a particular ultrasound image. But what I want to impress upon you is that these are very traditional computer vision problems. That is to say, those of us who work in vision, we're very familiar with these types of problems. They just happen to be applied to medical images. So I just want to give you an example of, oops. So I just want to give you an example of the sort of thing that we work on. Here what you're seeing is, unfortunately, here what you're seeing is somebody measures a sonographer taking someone's cardiac health. What we're doing in real time is first assessing the quality of the view, and then also in real time segmenting each one of those frames. And from there, all on device, estimating someone's ejection fraction. That is the fraction of blood being pumped in and out of the left ventricle. So this is the kind of application that somebody in the ER might do. Again, as I mentioned, you might come in. What you really want to do is quickly get a sort of measurement that you can assess a patient and maybe pass off that measurement upstream. So these are sort of applications that need to be done very quickly and in real time. One of the things that we are also working on, aside from a number of these types of automated measurements or assessments, is what we call acquisition assistance. The intuition here is that right now, if you want to use ultrasound, you have to have been trained in ultrasound for a long period of time. We really want to open up ultrasound to a whole new class of users. In the short term, that means people who are general practitioners who would otherwise call out for an ultrasound exam to be done by a specialist. In the long term, you might imagine putting this in the hands of a technician or a paramedic, somebody, again, who doesn't have those years of training, but still needs to be able to find an image, to get an image that's diagnostically relevant. So what we've built is a system that can indicate to a user through, in this case, an augmented reality interface, exactly how to move the probe in order to acquire a diagnostically relevant image. So what you're seeing here on screen is an operator moving the ultrasound probe. The iPhone screen has been mirrored here, so you'll be able to see when we've found the right image, you'll see a green check mark. And when the probe is moved off or turned in the wrong direction, you'll see these augmented reality arrows indicating to the user exactly how to move the probe to find the correct image. So this is the sort of application where we could enable someone who's never used ultrasound before. We can put the probe into a random person's hand and have it guide them to find a location that's diagnostically relevant, at which point they can record a short video of the ultrasound content and have that be interpreted either by a teleradiologist or by an application that's running on device. So of course, one of the big challenges in building some of these applications that we're working on, we require a lot of data. Big problem, it's really hard to get medical images, right? We can't just pop a search term into Google and get all the kind of images we want. Getting our hands on medical images has a whole bunch of hurdles. There's privacy hurdles, there's legal ones, right? We can't just knock on hospitals' doors asking for to turn over large numbers of images, and of course financial hurdles. So in practice, we generally have to make do with the images that we have available. That is to say, if we're working with clinical partners, they might work with us to gather data. That data might not be ideal, it might not be exactly what we're looking for, but we need to work with what we have. So this is the environment that we work in, which is to say that we might get a data set of ultrasound images, and these ultrasound images were taken from many different types of devices. So there's a Philips image here, there's an ultrasound image from a GE machine here, and this is from a Sonocyte device. And as you can see, each one of these devices produces images that are just qualitatively different. And the challenge here is that we need to be able to train a model on these images that look very different, but we need them to work on not the Philips image, the Philips device or GE device, but rather we need them to work on butterfly images, which necessitates the use of domain adaptation. So for those who aren't familiar, I'll just describe what the problem of domain adaptation is at a very high level. So we have some source. This is some data set that's not in the domain that we ultimately care about. We have a lot of this data, and it's beautifully labeled, which is great, except that we don't care about that domain. What we really care about is this other domain, our target domain. We don't have a lot of data in this target domain. And it might be labeled, it might not be labeled. So the problem that we have is we need to be able to train a model on the source domain, but have it actually work in the target domain. So here's a concrete example. Imagine we have a bunch of horse images. That's our source data, and they're all beautifully labeled. We want to train a model to, I don't know, do something like pose estimation, but on zebras, right? That's a different domain. So if we were to do the naive thing, perhaps, and train a pose estimation on the horse images, it would be very confused when it got to see a bunch of zebras in real life. In our case, we have a bunch of data that comes from various different providers, so GE, Philips, whoever it is, and we can train a model in that domain, but we really need those models to work when they're applied on butterfly images. So what we want to do is we want to take a third-party device, a bunch of images that came from let's say a GE device, and take that entire data set of images and change them at the pixel level to make them appear as if they came from a butterfly device. So the tool that we're going to use to do that is a generative adversarial network. And just at a very high level, the idea here is that we have two different models. There's a generator network that's going to take an image in, and it's going to alter the pixels. So the network is going to convert the image to look like something else. In this case, this is an example of a super resolution approach that's going to take a low-res image and make it high-res. That's the purpose of the generator network. The discriminator network is going to take a data set of high-res images, and its job is to discriminate between real high-res images and the fake high-res images that are produced by the generator network. So in practice, while we're training these two models, each one of these are effectively working against each other. The discriminator is trying to discriminate between real and fake, and the generator's job is to fool the discriminator. So some related work. Anyone not familiar with this work? I made a little bit of a splash. I guess most people. This is the cycle Gann work. So in this work, what they did is they took a pair of, they have two domains, like the zebras and horses that we saw before, or maybe summer and winter images, and they train a very particularly structured network to map between these domains. So this is intuitively the sort of thing that we're trying to do. A lot of the work that I'm going to talk about came from Harry Yang, our intern last summer. One of the first things we started is implementing this exact thing. So we re-implemented this cycle Gann work, and this is the kind of image it produces. So you have a bunch of horses here. We pass it through our generator network, our horse to zebra generator. And this is the kind of image we get, and you know, there's something pleasing about it. It kind of did the job. But there's kind of a major problem here, which is, I don't know if everyone can see, but there's a bunch of zebra stripes in the background above this car, right? So that is, you know, that's okay qualitatively if you're like, you know, it kind of looks like a zebra, but this is really bad in the medical domain. Okay, so this is the sort of thing that we really need to try to guard against. So this is some work that I published at CVPR this past summer. And the idea behind this work is very similar. We have a bunch of source data. In this case, we have a bunch of synthetic images that were generated from a CG engine of objects on black backgrounds, along with their associated depth maps. And what we wanted to do is train a pose estimation model, really for robotics applications to do grasping. But the domain that we really cared about is one of objects on a very cluttered tabletop setting. So we wanted to take these synthetic images and essentially fill in the background to make them look as if it came from a cluttered desktop. And then we could use those transferred images to generalize in the domain that we actually cared about. And the thing that really was very important in getting this to work was the inclusion of a task loss. That is to say that while we were doing domain adaptation, we were also training the thing that we cared about, which in particular was a pose estimation. So intuitively, what we wanted to try doing is if we want to do something like view classification, you know, what part of the body this image comes from, we would want to do this domain adaptation at the same time that we're doing image classification. Although there's a limitation that I'll point out here, we'll talk about it a little bit later, is that when you add a task loss, you need to be really careful about guarding against certain types of transformations. So for example, there's a problem in this space called label remapping, which is to say that one way that the generator can fool the discriminator is to take, let's say in this case, a heart image and make it look like a lung image. Well, the discriminator is totally fine with that because it might look like a totally realistic lung image. That's obviously not what we want. So if we had added a task loss to ensure that the image, once converted to our target domain, looked like a heart, we wouldn't get that kind of label remapping. But even that is limited. So this is an example of something that such an inclusion wouldn't capture. So here you can see this is a heart here in our source domain. This is a particular view of the heart called the apical 4-chamber view. We've converted it to look like a butterfly image, and we've converted it back using the cycle Gann approach I'll talk about in a second. Now you can see that, you'll have to just believe me that this looks like a butterfly image, but I think everyone can see that these are not the same heart, right? There's clearly something very different about it. So even the inclusion of a task loss that is a classification may not catch all the artifacts that we might be worried about. So let me first talk about our first approach here, which is, and I'll start by reviewing the cycle Gann architecture. So here we have a bunch of images from the source domain. These are GE or Philips images. We pass them through our source to target generator network. So this takes a Philips image, makes it look like a butterfly image, and the discriminator network is trained to try to discriminate between them. And then we have a target to source generator network which attempts to map back from the butterfly IQ image back to that original Philips image. Same thing for the target. So we take a target image, we map it to the source using that exact same network, and the same thing happens in reverse. We're going to map that source image back to target. And all we're going to do in the beginning is add this task network. In this case, it might be image classification. And just remember, this is being trained on target or transferred images, okay? So remember, the source data set doesn't have a lot of labels. All the labels are, sorry, the target domain does not have a lot of labels. The source domain does. So once we take the source images and make them look like target images, we can now train a classifier on those fake target images because we have all those images that are in our source domain. Make sense? It's a little bit confusing. Cool. So with that, that did reasonably well. But this particular type of architecture is very hard to optimize. And we really wanted to get away from that and build something a lot simpler. And this is what we came up with. In a nutshell, there's really two major components to this network. There's an autoencoder for our source domain, and there's an autoencoder in our target domain. Okay, so we have our source image. Our source encoder encodes it as some sort of hidden vector. The decoder decodes it back to the original, and we're going to train it to reconstruct the source. Same thing with the target. And there's something very particular about this architecture, which is that most of the encoder and the decoder are shared among both source and target domains. Okay? So the intuition here is that the first couple layers of this network are particular to each domain. You can think about it as really only capturing low-level image statistics, but everything higher up, which is capturing very high-level concepts, those are shared among both those domains, with the hope that we are effectively embedding both of these images into the same manifold. So there's a couple losses that we need to train this thing. So we have an autoencoder loss to make sure that when we encode the source images and then decode them, that we get the same image back. The same for our both source and target. We train this source softmax loss, in this case it's classification, on the source images. Keep in mind also the classifier we use the same trick about sharing weights. So the classifier, first couple layers of the classifier are not shared. Everything else is shared across both domains. In this case, we're going to use an adversarial domain loss, which is a discriminator which is attempting to predict which domain each of those hidden vectors came from. And the intuition here is that we want to ensure that the hidden units here don't contain anything that's specific to either domain. So if that's successful, the encoder is essentially going to strip out anything that's particular to either the source or the target domain. There's one really, really important last bit of this, last bit of the loss. This is what really makes this work. And this is that we take our source images, those are Philips images, we encode them as hidden vectors, and then we decode them using the target decoder. And that's how we train the thing that we really care about. In this case, it's a classification network, although you'll see we'll swap it out later. So in practice, we're going to iterate between training the discriminator and the classifier. We're going to iterate between the discriminator and classifier as one step, and then we're going to train the generator for everything else. Okay, so how do we actually evaluate this thing? Well, we're going to train our source data set, as I mentioned before, are a collection of images from other ultrasound devices, and we want to test it on butterfly devices. And we're going to do two different tasks for evaluating it. The first is view classification, which is what part of the heart was this particular image come from. And the second one is estimating the diameter of the left ventricle. So this is for that task I mentioned before, that ejection fraction. So just to give you a rough sense of how different these could be, this is just a visualization of different views of the heart. So depending on where you place the probe, you're obviously going to get a slice through the heart at radically different places. These are some examples of what some of these slices actually look like in practice. This is just an example of how real butterfly images look like compared to synthetic ones. You might not be able to tell the difference between them if you haven't stared all day at ultrasound images. So how do we actually do in practice? So our baseline, quantitatively, our baseline was developed by just doing the naive thing. We took all the source images, we trained on them, and then we applied them in our target domain. And that got about 74%, which isn't atrocious, but obviously far from where we really want to be. The second thing that we did is we took that cycle Gann and task loss idea, and we trained that to map from the source to target images, and that got about 95% accuracy. Our domain embedding network gets about 1% better than that. So there's still a little bit of room to go there, but we're really happy. The domain embedding network is actually really, really easy to train. There's no fiddling with tons of parameters, and the code is very, very straightforward. So that was a big win for us. In the second task that I mentioned before, we want to evaluate the left ventricle diameter. So this is the amount of blood being pumped in and out. Here, using only third-party data, we get this, the way that we evaluate this is with a metric called mean points diff. So this is the average distance of the points in the image plane. So using the naive approach gets about 13%. Using our model gets about 1% better than that. It doesn't look like a small number, but when that mean points diff is translated into an ejection fraction number, the difference or the swing in how much different that ejection fraction number can be is about 5%. So that's actually quite large. That's the kind of difference that might differentiate a healthy patient from an unhealthy patient. So this was also quite a big win. Now there's still a bunch of open research questions that we have yet to solve. The biggest one, and I alluded to this earlier, is how do we avoid introducing artifacts that aren't covered by the task loss? Right? So if we want to guard against a certain type of artifact right now, we need to add a new task loss for every type of artifact that we're worried about. That's very unideal, and it really complicates training. That, to me, is a totally open research question. The second thing is, how does this scale with the number of input domains, right? So we can imagine having a separate encoder and decoder for Philips images and a different one for GE images and so on and so forth. As the number of domains increases, do we just scale linearly? Again, that seems somewhat unideal. And the last one is there's actually been a huge amount of research in this area in the last, 6 months alone. This is a very, very hot area of research. There's a lot of different ideas out there, and it's still not totally clear what are the really, really critical parts that make these networks work. So I think this is also a sort of a rich vein. So to wrap up, ultrasound is extremely useful. There's been a lot of big promises behind ultrasound for a long time, but it's largely been limited by the price and form factor of the hardware out there. And Butterfly has provided a totally new, low-cost device that produces very high-quality images. There's no big standardized image net for ultrasound just yet. This is something we're really interested in. But we have shown that for a bunch of our automated measurement and assistive technologies, we can solve a lot of these problems. To solve a lot of these problems, you don't have to wait until we go out and collect a lot of that data. We can use data from a very disparate set of sources. I'll just throw this out there. We are hiring in terms of, we're looking for machine learning people, cloud people, data scientists. And with that, I'll take questions. So we work with a bunch of different clinical providers who, these are hospitals or other partners who spend a lot of time anonymizing the data for us and then giving it to us.
Do you have to pay the hospitals for access to the data, or what did they request in exchange?
There's different arrangements with different providers. So sometimes there's an exchange of money, other times it's an exchange of technology. Definitely, yeah. I'm actually going to show you the device right now. So this is the IQ. This is all the infrastructure required.
So that's very helpful for the developing world then.
Hugely, hugely. Let me see if I can get this demo to work here, and then I'll take a few more questions after. Sorry. I'm going to volunteer myself. Just want to see what the connection looks like. It's pretty good. Cool. So the first thing I'm going to do is show you some of the basics of just how easy this is to use. I mentioned before that different ultrasound devices use many different probes to connect to image different parts of the body. So on this device, we have a simple iPhone app that does all the controlling of the device itself. So imaging different parts of the body is as easy as selecting the different, what part of the body you want to image. One thing I didn't mention is exactly how this works. That's really a whole lecture in and of itself. But the really cool thing that Butterfly has done is built an ultrasound platform with an entirely different technology. Butterfly has essentially managed to put ultrasound on a chip, which is why it's so inexpensive, but still maintains such good quality. And what the iPhone app is going to do is by selecting any of these modes, it's actually altering the image characteristics of what the chip is actually doing. So I'm going to go ahead here and select carotid. So that's my carotid artery right there. And what you're seeing is the visualization of blood as it's making its way from my heart to my brain.
And the two different colors indicate?
That I'm a bad sonographer.
It's venous or arterial?
Say again?
It's venous or arterial flow? To the heart and from the heart.
Oh, this is from the heart. So let me now show you, so this is my carotid. I'm now going to switch modes. I'll switch in a cardiac. In order to do this exam, I'm going to have to lie down like a patient might. And what you should be seeing on screen is my heart. Indeed. So what you're seeing here in real time at the bottom is this quality indicator. This is going to show you how good of a capture this is. You can see it's a good image here. I'm going to go ahead and record a little short clip. And right there on device in real time, I've computed my ejection fraction, which is 62. It's a very healthy percentage. And the quality indicator here is a 92, so it tells a clinician that image was good enough to be trusted. That
Was that done processing on the device?
everything is done on device in real time.
So you can be offline? You don't have
Correct.
to- there's no cloud.
Correct. Except if you want to show this during a lecture.
No, yeah.
Are you collecting all these images so you can further, when they use this device?
Yeah, that's a great question. So one of the things I also didn't mention is Butterfly's cloud. The way that works is that if you are in a Wi-Fi area, it's very, very easy to collect an image that you're, let's say, doing on a patient and immediately upload it to the cloud. Let's say you want to share it anonymously with someone. You want to get a second read. So all that is enabled by Butterfly's cloud, and everything is stored online.
That 92% score you showed, how does that compare with, say, a $25,000 machine?
Yeah, so that 92% score is our own quality metric, which is our own indicator of how good that number, the ejection fraction, is in terms of reliability. So we haven't done, let's say, side-by-sides on taking other ultrasound systems images or captures. All the calibration has been done using images from our device.
So what's like the expected standard from a hospital grade device?
What is the?
What's the expected standard from a hospital grade device? How do they?
There really isn't one, is the short answer. They trust their sonographers or cardiologists or ER doctors to either eyeball it or measure it manually. So depending on what situation they're in, there are a bunch of automated tools. No, I would say automated, I'm sorry. There are a bunch of manual tools on a bunch of these very expensive ultrasound systems. What they don't have is something purely automated like we do.
I think the question is this a metric that has to do with your loss function, or are you evaluating then some metric of performance for your system that you could apply to a standard?
Oh yeah, it's the latter. It's an externally evaluated metric. We could easily apply it to something else, but
So you said it's all the AI happens on the device, but you have an algorithm that's already updating itself. But I came in late, but I assume it's been changing the classifier constantly. How does that get pushed to the device?
that is an excellent question.
Yeah.
The short answer is that we're still trying to figure out how that's going to work. This actually hasn't hit the market just yet. We're going to start selling in 2018. So the exact details about how that's going to work still are going to need to be worked out.
I'm sorry, I came in late. It's a neural network, I assume? Is it like a deep learning, a multi-layer?
Correct, yeah. Yeah.
One of the concerns that you see when you apply the deep learning system either in a medical context or another mission-critical context, arguably something like echocardiology is going to fall into the domain of characterizing a patient's health, a diagnostic. So FDA has certain guidelines in terms of both software development and methodology for measurement. And you see the same concern in things like asset management and insurance, that organizations will say, well, the deep learning solution is excellent in terms of the net outcome, but because of the fact that it's a black box process, we're having a hard time, in a sense, gambling on it. You don't have the same confidence. So we'll actually elect a more old-fashioned algorithm because we understand it. What are you seeing as much as the evolution of this, developing a software stack for a medical application in terms of either uptake on the FDA side, general certification, or the process of qualifying these things?
Yeah, that's a super excellent question. So there's two parts here. One is, let's say, the FDA's, how we and others are working with the FDA to roll this stuff out. And this, I guess the second part is, how is the medical community responding to advances in neural networks, let's say, and their adoption of this? Did I characterize that question correctly?
Well, I mean, it's sort of rubric of
Yeah, what I would say is that I think the medical community in general has been a lot more conservative. That is starting to shift. There's a greater and greater realization that these things do work, and we shouldn't trust it. We should just test it in large-scale settings. So one of the things that we're involved in is doing large-scale clinical validation and really trying to make sure that we have evaluated not just a couple images, but the full long tail. The second thing is, it's true, interpretation is very important. People do sometimes get worried that they can't understand exactly why a network is making the prediction that it's making, and that's another one of the areas that we're very interested in working on, is really trying to show a clinician exactly why the algorithm is making a particular decision. That quality indicator is maybe the weakest version of this, which is like, how confident are we in that prediction? But as you might imagine, and in fact alluded to, there's many cases where you really want a much better sense of understanding about exactly why the network is making a particular interpretation, so that the clinician can look at it and understand, like, well, that makes perfect sense. You've provided the evidence for me, I'm convinced. In terms of FDA, the FDA is also evolving, and I would say they have made a number of steps that have demonstrated that they are really trying to find the right balance of ensuring that safe products are put out into the market, while also understanding that it's a fast-changing tech environment. I'm very reassured in general about the efforts that they're trying to make to evolve their own processes.
So kind of to follow up on that, on the statement of the black box, I assume you built the whole classifiers, everything, you built yourself. So you should be able to trace any decision made in case they justify it. I assume the gentleman was alluding to sometimes in finance, when you build neural networks that project someone's credit history, you have to justify it for the OCC. Are we talking about the same thing here? Or can you?
Yeah, we are. What I would say is, even if you own the network, even if you know exactly how you built it, exactly what it means to interpret it, or exactly understanding exactly what how the machine came across a particular prediction is actually a very open area of research. It's not simply an open and shut case of like, well, this is clearly the right answer. So there's actually many different approaches. Different people think that different ones are more reliable than others in terms of truly indicating why a particular prediction was made.
I heard the FDA commissioner made a comment that if a doctor reads the image, that he's okay with it, meaning that they use your device and that you do this diagnosis as a physician, you're okay with it.
Yeah, that's a very good point. Everything that I've shown here is not a diagnosis. It's considered a measurement. So these are indicators which a clinician will use in order to aid a diagnosis or to produce a diagnosis. So those do require different levels of evidence.
Do any other applications come to mind for your model architecture for transferring between domains?
There's really a whole host of other data sets out there, and I suppose like applications. Certainly the one of like learning from synthetic images is a really popular one. This is sort of been the dream of domain adaptation, which is no more collecting expensive data sets, pay a graphics guy to come and build a synthetic world, and they make just an unlimited amount of data. You run domain adaptation, and you have the most amazing data set ever. Right, so this is still, I think, beyond us today, but I'd like to think this pushes us a little closer in that direction.
So I can see why the domain adaptation would be good if you're just trying to train like a classifier, like transfer like image classification from the target to the source, or source to target. But like, what if you're trying to do like segmentation? Like, how do you can't translate the segment? You're not also translating the segmentation, right?
So actually, segmentation is a great example of something that is a more powerful task tower. Right? Think about it this way: that example I gave of the heart, where where we could have changed one heart to still look like a plausible heart, but it was clearly the different one. The segmentation effectively is a much more particular set of constraints that the network needs to adhere to in order to do its job successfully. So there definitely are a bunch of segmentation, domain adaptation, plus segmentation architectures out there. And I would say if you have segmentation data, use it, because in this case, the more fine-grained details you have, like those found in pixel-wise segmentations, the less room to operate your generator has. Does that make sense?
Well, are you also, so do those properties let you transfer the segmentation? So you have X and Y, you transfer both X and Y from the domain with lots of data to the domain with no data?
Yeah, exactly. It's think about it this way. If you only have a classification label, like is this a heart image or a lung image, what the generator can do is take a source heart and it can, make it a lot bigger. Totally plausible, it's still a heart. But the segment, if you train a segmentation at the same time, that segment in the source domain is not going to line up nicely with that fake heart, right? Because it's so much bigger all of a sudden. So the generator, in order to satisfy the segmentation loss, is going to have to correct that enlargement of the heart.
An explanation regarding the picture that you put red and blue, because somebody asked. If you're in the same vessel, the red is blood coming toward the transducer, the blue is not going away. If there are two vessels, one is artery, another one is a vein. And I have a question now. And I understand that the end point is to diagnose pathologies, right? I mean, of the deep learning. How do you plan to have this automatism giving the diagnosis to the users?
There's certain diagnostics which might be done from just imagery. There's other diagnostics which can't, which you need more information other than just the image. So we're not I would say in the short term, what we're not working on is diagnostics, but rather automated measurements, which can be used to speed up or assist clinicians out in the field. Longer term, there might be certain things that we might be able to do diagnostically on the device, but they will of course be limited to what we can infer from just the images alone.
So going back to your measurement point, do you guys think about or work towards creating a measurement that goes beyond the traditional kind of canonical ultrasound measurement, like getting something that looks like an ultrasound machine but better, instead doing things like going down the road of super resolution or combining temporal image information so they can present to the clinician some view. It doesn't have to look at all like an ultrasound, but something that's more informative based on maybe more data they can collect.
Yeah, 100%. The super resolution, the idea of using super resolution to improve the quality of what comes out of the raw signal is definitely something that we're interested in. It's also, it can be a little bit of a dicey thing, right? We want to be just positive that we're not introducing artifacts where there are not ones. But it is an area that we're very interested in. In terms of different views, there's certainly a lot that can be done there. And there are existing tools which provide, I would say, similar assessments to the ones that we might be able to provide. So for example, tracking movement of different parts of the heart, or tracking blood flow. So these are things, or even flow of liquids through different parts of the body. These are things which aren't in the image themselves, but which we might be able to add on to add additional understanding or interpretation of the image. In themselves, not diagnostics, but rather tools to help better understand what's going on.
In terms of your automatic measurements, where do you get the labels of, let's say, how long things are, and how does your algorithm find the image?
Yeah, so we work with a team of sonographers and cardiologists and other clinicians, and they provide a lot of those annotations for us.
So they hand draw these things on the external.
Correct. Correct. Yeah.
From a business perspective, what are you seeing in terms of the effectiveness of medical institutions about data? They obviously see this coming. So if I'm Columbia or I'm Mass General, and I own bajillions of X-ray slices or MRIs or CTs, I know someone's going to come around and ask for those to train their networks, to make their networks smarter, and thus create a product. Is the general consensus that the organizations tend to be sharing the data, or are they saying to themselves, you know what, there's a new shekel to be made here?
That's an excellent question. So I had alluded to it very, very briefly in one of my earlier slides, which is there are financial hurdles in getting the data, and you put it perfectly, which is that data is worth something. And so there are definitely some institutions that we've talked to who have been very reluctant to do any sort of data exchange that doesn't involve a large profit. But there's a number of other clinical institutions that we work very closely with, and for them, the real target is patient health. Right? For them, they really want to understand exactly how this can be used to improve patient care, and if it happens to be sharing anonymized data, that's an excellent approach.
One question, you're using measures of the image in order to gain some sort of idea of the position of the sensor. And I wondered if you considered in your product process, you must have, about simply embedding some sort of 3D sensor to sort of track the location of the sensor on the body, and therefore use that as some sort of, at least to get users into the right.
Totally. So our requirement or constraint there is we really don't want to, we want to add as little as possible. We really want to have like just the probe, just the phone. That's really it. So it certainly can be solved in a bunch of other ways, but we really wanted to make it as liberated as possible from additional constraints.
I have a two-part question. First, why the iPhone? And second,
It's a good question, yeah.
And second, isn't having it wired, there's some challenges that come with that too?
To wired connection.
Yeah.
Yeah, those are both excellent questions. The first is most doctors in the US have iPhones. I'll tack on to that Android support will come next year.
So it's not an issue of the device not being capable of
Not at all.
processing?
Not at all. In fact, so I mean, both Android and the iPhone have made a number of very substantial advances in some processing on device that are really geared towards running these very expensive neural networks.
I assume Tesseract is involved here at some point?
Yeah, I can't get into some of the low-level stuff. Your second question about the wire, this is also something that's come up. There is at least, I think, one other device that uses a wireless connection. For most of the clinicians that we work with, it really hasn't been a problem. This is something we might revisit in the future, but right now, the wire is actually surprisingly durable.
Yeah, I guess when I hear you use the word in the field, I'm also thinking about military applications. And if you're talking about soldiers that are in the field where somebody has to get diagnosed before they try to ship them out or treat them right there on the spot, then having it wired becomes a little more challenging.
Sure, absolutely true.
Sometimes there are situations where there are a lot of volumes to analyze, and I wonder if you started maybe to develop 3D.
Indeed. That's all I can say about that.
Are you open to collaborations with companies who are looking at heterogeneous dataset, ensemble, data analytics in conjunction with these?
Yeah, we're certainly not closed off to any kind of collaboration. If that's what you do, I'm happy to talk after.
So what are the next main hurdles for implementation and the actual patient use?
Well, one of the biggest one is just, I think something I mentioned earlier in terms of clinical validation is, in the academic world, and maybe certain industrial applications like 98% accuracy is good enough. Obviously in the medical space there's a much higher hurdle to cross there in terms of accuracy. So one of the things that we're really spending a lot of time on is clinical validation and ensuring that this really satisfies the long tail distribution of things that we run into in the real world.
Is there a threshold level that needs to be like a 99.5, or is it?
Yeah, the short answer is, or the thing I think that's fair to compare to is how good do humans do at these tasks? Ultimately, as long as we beat that threshold, we're adding value.
I don't know, maybe I wasn't paying attention close enough when you were scrolling through the different modes, the different body parts. Was there prenatal,
Yeah, so there are obstetrics applications. It's actually the FDA, it's a device that has the most FDA clearances of any ultrasound on the market, which is a natural consequence of the fact that it can scan the entire body, which is the only device that can do it.
Okay, cool, thanks.
How big was your data set when you trained your model to either pay for the ejection fraction or for early segmentation or for view classification?
I'm not sure if we can go into that. Yeah. Sorry.
Is the goal to wean yourself off of the GE and Philips data once, adoption of your device?
Yeah, absolutely.
How much do you think you can increase accuracy once you have, removed that sort of translation aspect from a different device to your own device for training purposes? Like, is there another percent that you can increase there from 97 whatever to 98 something? Or like, what's the room, that you can gain there?
Yeah, that's a really great question. I mean, the short answer is I don't know. I suppose like this is the sort of thing that's very data set specific. Slightly longer answer is that it definitely helps to have data that comes from the device. The process that we trained is actually reasonably good at making things that are hard to discriminate from real butterfly devices. So it's really more data that's more important than more butterfly data.
Have you found that technicians have differing opinions of the same image from your device?
You mean if they look at, like, you mean can they tell the difference, or do you mean like?
Like if they're looking at a GE, image, they're like, okay, that's this. This is what I think, this is the measurement. But then when they look at, raw images from your device, and they're like, actually, I think it's this, and someone else thinks it looks like something else.
We haven't done a sort of side-by-side comparison of annotation. There is certainly side-by-side that's done when it comes to getting a device like this cleared. So comparisons of image quality are hugely important, not just for FDA clearance, but also for ensuring that there's real value.
I was thinking on the, in terms of getting more data to train your device better, obviously more images better. Do you see a need for, say, as you said, an indicator as opposed to a diagnosis for getting the measurements? Thinking on the East Coast, we have lots of medical facilities all over the place. In the Midwest and some other very rural areas, there are very few, very hard to clean. So that might be a market where, the emergency room, maybe they could, or do you see that as an option that they could, the emergency room, they could scan to get an indication and then get an expert result, say, well, here's what we don't like.
Absolutely, that's a beautiful use case. This is the exact kind of use case that we're looking for with our acquisition assistant, which is when you're in a rural situation, you might not even have access to a sonographer who can capture the view that you need, right? So you really want something that will help you get that measurement. Once you do, the ability to upload it to the cloud or something else where somebody remote, like a teleradiologist, can provide the interpretation necessary. That's a great use case.
Let's take one more question.
Okay. Sorry. Yeah.
So one thing I'm curious about is that you have this model that's sort of derived from presumably very protected private HIPAA data.
Yeah.
Are there any concerns about the model itself and the dissemination of like the weights itself being potentially dangerous because of the constraints?
Yeah, that's a really great question. There would be greater concern if we released the weights or if it was easy to pull them out of the application. That's pretty darn non-trivial. There is a lot of really cool research now on like how to train networks to ensure that one can't back out some of that HIPAA information. That all being said, all of the data that we train on is totally anonymized. This is a really, really big and important aspect to everything that we do, is like when it comes to what we on the machine learning team do, we are just totally divorced from anything that can be regarded as